Greetings to everyone attending this program. Those of you in this hall and those of you online, a warm welcome. I am Manjuli Kawaz from the Division of Health and Humanities, St. John's Research Institute, and I'm happy to be your host for this, the sixth public lecture in memory of our dear Professor Prakash Shetty. We're privileged to have Dr. Nandini Shetty, who's joining us online, various members of the Shetty family from across the world, Dr. Shetty's students, colleagues, and friends. I call upon our director, Reverend Father Jesudas Rajamanikam, to welcome the gathering.
Good afternoon to everyone. It is my privilege to welcome you all to this special event, a lecture in memory of Professor Prakash Shetty. We are gathered here today for a talk that promises to enlighten and inspire us all. I am particularly honored to welcome our distinguished guest speaker, Padma Shri Awardee and Professor Emeritus, Dr. Rajendra Badwe, the former director of Tata Memorial Center. Dr. Badwe's contributions to oncology and cancer research are globally recognized, and we are truly fortunate to have him here with us today to share his insights on the topic Indian society and cancer. This lecture is not only a tribute to the legacy of Professor Prakash Shetty, who dedicated his life to public health and academics, but also an opportunity to reflect on one of the most pressing health challenges of our time, cancer, and its impact on Indian society. As a nation, we face unique challenges in combating this disease, and Dr. Badwe's experience and visionary work will help us better understand how we can address these issues with both scientific and compassionate approaches. In many ways, the topic of today's lecture aligns perfectly with our values. Cancer, a disease that affects people from all walks of life in both a public health and social issues. Dr. Badwe's deep expertise, having spent decades pioneering cancer research and treatment at Tata Memorial Center, will shed light on the socio-economic and healthcare dimensions of cancer in India. Before we delve into this highly anticipated talk, allow me to introduce St. John's National Academy of Health Sciences to those who may be joining us for the first time. Established with a mission to serve the underserved and the marginalized, St. John's has grown over the past 6 decades into a leading institution in healthcare, medical education, and research. At St. John's, we are guided by the profound belief that the least also deserves the best. We hold steadfast to our mission of delivering quality care at an affordable price, making sure that every individual, regardless of their background, receives the best medical attention possible. We believe that healthcare is not a privilege for few, but fundamental right for all. This ethos drives our efforts to provide world-class healthcare, particularly to the underserved and marginalized, ensuring that no one is left behind. Events like this lecture reminds us of the deep connection between our mission and needs for continuous learning and dialogue, especially on issues that affect millions of lives. Dear Dr. Badwe, your presence here reflects that commitment to learning, service, and the highest standards of excellence in healthcare. We look forward to hearing your thoughts and insights on how cancer affects our society and how, as a community, we can combat its rising burden through awareness, early detection, and comprehensive care. I also extend a warm welcome to all the participants, faculty, students, and healthcare professionals present here. Your participation exemplifies the passion and dedication we all share in our fight against cancer. And I'm confident that today's lecture will leave us inspired to further our efforts. Thank you all for joining us today. And once again, a special thanks to Dr. Badwe for sharing your wisdom with us today. We look forward to an enlightening and transformative, informative session today. Thank you and all the best. God bless.
Thank you so much, Father Jesudas, for that warm welcome and for setting the tone for today's public lecture. Let me just give you a brief background to why this public lecture. A little bit first about Professor Prakash Shetty. He did his undergraduate and postgraduate studies at the Christian Medical College, Vellore, before joining the Department of Physiology at St. John's. He then proceeded to Cambridge in the United Kingdom to complete a PhD. On his return to St. John's, he ran the physiology department and set up the ICMR Nutrition Center. However, he had a wide range of interests outside of academia, including in the history of medicine, literature, and the arts. His departure to the London School of Hygiene and Tropical Medicine and subsequently to the Food and Agricultural Organization was a blow to St. John's, but he continued, however, to maintain his ties with this institution till the very end. Dr. Shetty envisaged this public lecture with discussions over the years with Professor Mario Vaz, the then head of the Division of Health and Humanities. The lecture was brought to fruition through the efforts of his wife, Dr. Nandini Shetty, and his family. The lecture was to be on a topic that could speak to people of all walks of life, an area of science which affects public life, or the intersection of science and the arts. Keeping in mind this idea, the lectures in the past have dealt with a range of issues delivered by people embedded in their fields. Today, in continuance with that aim, we are privileged to have Dr. Badwe speak to us. At a personal level, I feel particularly fortunate, since in a sense, this is a culmination of an association that we have had for several years with the Tata Memorial Hospital in the humanities component of their innovative Patient Navigator KVAT program. A little bit about this session. After the lecture, we will have a question and answer session. So please write down your questions. For those of you online, please use the chat box for this purpose. We will now have Dr. Sumitra Mutaya, a former colleague of Dr. Prakash Shetty, and who spent over 10 years here at St. John's Medical College, and presently the director of the Aboriginal Health Sachs Institute at Sydney, and also the adjunct associate professor, School of Public Health, University of Sydney, who will share her personal memories of Dr. Shetty in this recorded message.
Good afternoon. Family members of Prakash Shetty, Dr. Rajendra Badwe, invited guests, colleagues, and friends of St. John's, greetings to you all. I am Sumitra Mutaya. It's a privilege to be asked to say a few words about Professor Prakash Shetty at this annual public lecture instituted in his honor. Firstly, I would like to thank Manjulika and Mario Suarez, Tony Raj and other members of the organizing committee for their efforts over the last few years to keep alive the memory of Prakash Shetty, who has a special place in the hearts of so many of us gathered here today. I was introduced to Professor Shetty in late 1988 while I was visiting a friend, Lisa Koshi John, who was then working at the Nutrition Research Center, Department of Physiology at St. John's Medical College. A week later, I joined the center as a young postgraduate in nutrition, not having the faintest idea that I had walked into a premier laboratory of nutrition research in the country. Though Prakash Shetty's research at the time was primarily focused on energy metabolism, he had developed interest in infant and child nutrition. I was assigned a field study of infant and child growth and nutrition across different socioeconomic households in Bangalore to work on, alongside Lisa Koshi, Sumita Digavi, and Tilaka Bhaskaran. Working with mothers and babies left a lasting impression on me and led to a lifelong interest and commitment to improving maternal and child health and nutrition outcomes in low and middle income countries. Though I was the junior most researcher in the center at the time, Prakash always made it a point to see me, offered guidance, and encouraged me to keep going. I found it rather unusual that a professor trained in medicine would take a cross-disciplinary approach to solving problems and commit to mentoring non-medical students such as me. His uncommon foresight bore fruit through a cohort of well-trained researchers in physiology, nutrition, and public health who carry his legacy. The work he began in the 1970s continues to this day at the now Division of Nutrition at St. John's. Though he was an exceptionally gifted teacher and researcher, Prakash Shetty was humble and approachable. I experienced his warmth, generosity, and kindness in greater measure when he made it possible for me to spend over a year with him at the London School of Hygiene and Tropical Medicine, one of the world's leading public health institutions. He arranged for me to stay in his own home in the initial weeks. Prakash and his wife Nandini, together with their children Dushyant and Meghna, were incredibly welcoming and helped me to adapt to life in the UK. My time at the London School in many ways was life-changing, opening new perspectives and providing me new ideas on how to approach my work. At the school, Prakash reformed the school's nutrition research with a new focus on public health, and he became head of the public health nutrition unit. We spent a lot of time working together at the school, and our conversations would almost always extend beyond work to other interests we had in common, including our common love of music. Prakash Shetty and I always stayed in touch and kept each other updated until the very end. I consider myself greatly privileged to have had Prakash as my teacher, mentor, friend, and guide. In the words of Luke the Apostle from the Gospel of Luke, chapter 6, verse 40 in the Bible, the student is not above the teacher, but everyone who is fully trained will be like their teacher. God, as part of his great plan, chose me to be trained by Prakash Shetty. Thank you.
Thank you so much, Sumitra, for taking us down memory lane. She's online, but she said she would get too emotional, even though we told her we could assure the technology aspect of her talking. I now move on to inviting Dr. Hari Menon, Professor, Department of Hematology and Medical Oncology at St. John's Medical College, and a former colleague of Dr. Badwe, who has known him very closely over the years, to introduce our speaker to us.
Good afternoon, directors, Professor Badwe, and all my colleagues and teachers, and people who are online for this public lecture. It's a distinct honor for me and a privilege to introduce Professor Rajendra Badwe, who has been a mentor, a teacher, philosopher, and guide, and who has been a transformative force, as we would all agree, in cancer research and treatment in India. Dr. Badwe, currently Honorable Professor Emeritus and former director of the Tata Memorial Center, has for more than 35 years of his diverse experience as surgeon and oncologist and director, led TMH's or Tata Memorial Hospital's transformation into a premier cancer center, and expanding its services, improving accessibility and affordability. As a researcher, he has been instrumental in fostering collaborative work, enhancing cancer treatment outcomes, and advocating cancer awareness and prevention. Under his leadership, the Tata Memorial Center has flourished as a premier institution renowned for its cutting-edge research and commitment to patient care. He established the Indian Cancer Research Consortium. He launched the Rural Cancer Center program. He developed India's first comprehensive cancer registry. He implemented innovative cancer screening programs in the country, and to name a few. Dr. Badwe has also authored numerous publications and has been a guiding figure in various national and international oncology initiatives. Under his stewardship, the TMC has had the honor of plenary sessions, presentations at the American Society of Clinical Oncology. And for all of us who are in the oncology space, we know what a great privilege and achievement it is to be part of a plenary session of a premier conference in the world. And not too many centers have achieved this in a decade's time. And he is an international opinion leader in oncology, having developed breast cancer care, which is his area, spawning innovative research, integrating delivery systems, improving quality and cancer management programs, while giving a fillip to the capacity building of staff and cancer care delivery strategies and practices issues. As Madhulika just mentioned, the KVAT program, which has taken a new meaning as a model for patient navigation, something which we all need to address in every center, every large center, because that is something and an issue who has been instrumental in promoting this whole thing under the leadership of Dr. Badwe. He is an international opinion leader in oncology and has developed breast cancer care strategies, spawning innovative research, integrating delivery systems. His pioneering work on the timing of surgery has introduced a paradigm thinking or a paradigm shift in the thinking process for the important events that actually are timed around the timing of surgery. He has been a frequent speaker in a number of international and, of course, national conferences. And also, he is a recipient of prestigious national awards and honors and gold medals. The Padma Shri and the B.C. Roy Awards have been, to name a few, for his outstanding contribution to medicine. The Lal Bahadur Shastri National Award, recognizing his excellence in public administration, academics, and management. And his international recognition includes prestigious awards from the National Cancer Institute and the UICC, or the Union of International Cancer Control. At the personal level, I have been associated with Professor Badwe, and in several very close manners. We used to many a time share our lunchtime together, and he never used to even spare one moment to think and come across to the table to ask as to how everything was. And that is the way that we have as a person over here, always concerned about his colleagues and the way that they work and trying to improve things for them. And today's luncheon was nostalgic in terms of having you after a long time. Yeah, so today we are privileged to have him to share his insights and expertise in this public lecture. And I think even though I did not know too much about Dr. Prakash Shetty, I'm told that he was an inspiring teacher, and we just heard from his student. And I believe there's no one better than Dr. Badwe to do justice to Dr. Prakash's legacy. Please join me in inviting and in welcoming Dr. Rajendra Badwe to the stage.
Thank you, Hari. Thank you very much for that very, very flowery introduction. Director, Reverend Father Jeshudas, Associate Director, Reverend Dr. Charles Davis, Dean SCRI, Dr. Tony Raj, Dean St. John's Medical College, Dr. George D'Souza, and family of Dr. Prakash Shetty. It is indeed my pleasure and privilege to be here in front of you, giving a public lecture in the memory of Professor Prakash Shetty. And my interaction during lunch, I did mention that we are so much focused into activities, and we are reducing our field so that we become expert in one small area, that this vertical movement down has lost our understanding of what the horizontal spread of nature is. And that loss of vision is what I see here, perfectly personalized in Professor Prakash Shetty, who not only was a physiologist, but had many, many other aspects all coming together. So instead of that reductionist approach, he represented a unified approach. And I'll try and address the same kind of thought when I talk about society, Indian society and cancer. Let me warn you right at the outset that I'll be using a lot of numbers. So there will be lots of numbers that will come to you in this talk. And the second, I am an eternal optimist. So you will have lots of positive things. Don't think that they don't exist. They do exist, and that they are a reality. What I'll run through in my talk is essentially to something in it for medical individuals, something in it for some of the non-medical individuals, some of the regulators, and anybody who is planning healthcare delivery, all of it put together, since I was not too sure as to who all will be listening to me for this public lecture. I selected this topic only because cancer is becoming extremely common. And I will give you some evidence as to why is it happening, and also try and challenge, is it happening in reality? So let's look at some numbers. Cancer in India has a three-tier system, that we have altogether different numbers of cancer in cities. You go to mid-sized town and the numbers are different. From 100 in cities, we go down to 65, 70 or 60, 75 in mid-sized towns. And when we go to rural India, the numbers are even smaller, between 40 and 50. And you might say that we might be missing cases. But to date, I've written to multiple registries, not just in India, but across the globe, including Scandinavia. And not today, much earlier, somewhere in 80s and late 70s. And I found that there is not a single registry that documents death because of cancer without cancer being diagnosed. So we are not missing out cases. When I talk of some of the rural cancer registries in India, I find that we do house-to-house survey in a population which is about 2 to 3 million individuals in a given geographic area, and there is no cancer there. We do a house-to-house survey on an annual basis, and the numbers are small. To the extent that Bill Melinda Gates Foundation did invest in one of our rural pockets in Maharashtra, as to they invested about $2 million to understand why breast cancer is extremely low there. And it remained low for something like 40 years. From 1982, we were running registry there till 2002, the numbers were still about 9 or 10 per 100,000 women per year. That number stands at about 120 per 100,000 in United States. The same numbers are in Europe. So there is a graded increase from whatever, 40, 50 to 350 in United States. Suffice to say that we are less than a third of what United States sees. These are age standardized numbers. So you can't stand up and say that the life expectancy is much longer there and that's why they get more cancer. No, these numbers are age standardized incidence rates in population. And when we go to our rural India, it's about 1/9 or sometimes 1/10 in some pockets. So there is something that is changing over a period of time. And as the urbanization sets in, if you look at the Indian census, every decade, there would be some transition, some new urban pockets will come up, or there will be a lot of movement of semi-urban to urban or rural to semi-urban. The moment that happens in the next 4 to 5 years, the numbers start rising for this population. So there is something that is happening with urbanization, and I will allude to that as I go ahead. Why are we so different compared to United States? And there are some numbers under United States and some numbers under India. And I have written into bracket the letter S for some cancers in United States. And these are the cancers which are screened in United States. So their numbers are 350, 360 per 100,000, because look at prostate cancer. 9 per 100,000 in India, 50 per 100,000 every year in United States. Lung, 10 and 60. Colon cancer, 6 and 55. A lot of this difference of 6 and 55 is because of diet. Our diet is excellent. When somebody here says that I am non-vegetarian, that would mean that on maybe twice a week or thrice a week basis, there will be one of the dishes in his plate that will be non-vegetarian. There will be some leafy vegetables. There will be some more what we locally call koshimbir or salads. Now, all this, in addition, the non-vegetarian diet that is cooked is full of spices. If you go to any of the interior of Maharashtra or interior of Karnataka in some place, when meat is served, invariably there will be 2 or 3 nice green chilies on top of it. And you will be amazed to see that people merrily bite into it while finishing those morsels of meat. We look down upon it, don't we? But that's what has kept colon cancer low in this country. One, the quantum of the non-vegetarian diet, which is low here. If somebody in US says that he is non-vegetarian, then he will have cold cuts for the morning, a steak for the afternoon, some other non-vegetarian dish for the snacks in the afternoon, and the dinner also will be full of either red meat or some kind of processed meat. And using spices is very, very little in that. Majority of the dishes when they are served will have hardly any vegetables, some miserable potato in the corner, which will be left alone. Yet, today when we look at, we want the Western diet to come into our habits. What is it that is changing? I mean, we are having the same meat that they are having, the quantity is different. And the transit time, that the foreign material with foreign DNA moving in our intestine is much quicker because of the spices, because of the chilies, which is not the case there. And what I'll say now is not something that is for the whole country or civilization, but we are extremely fond of emptying our bowels first thing in the morning, which is not the case in the West. Constipation is a norm, which is, I mean, if somebody gets constipated here, he will be most uncomfortable. He may not come to his workplace. And I'll give you another example. We were running a study of a drug called neratinib for breast cancer. And this was an international study with 70 centers across the globe. Reporting when a new drug is used, usually side effects are reported across the world. The moment there is some side effect reported somewhere, and on an average, every week, I would get 2 to 3 letters from the central agency that so many individuals have complained of loose motions. We had about 73 patients on this trial. Not a single lady ever complained that she had loose motions or frequency of motions. Somewhere at the end of about 3 years, when we completed the trial and we stopped the drug, there were at least about 10 women who came back to us that we are constipated now. So you understand what norm is for an individual, which is good. In fact, that's excellent. And we should maintain that. That's about colon cancer. It is low. Let's keep it low. Oral cancer is diametrically opposite. We compensate for their lung cancer by way of oral cancer by the way we consume tobacco. Chewed tobacco is what gives rise to oral cancer, pharyngeal cancer. Some other forms of tobacco use can also produce nasopharyngeal and nasal cancer and paranasal sinus cancer. In general, tobacco used in any form produces cancer. That's all I would say. Breast cancer. Breast cancer is on the rise. The last data I saw from Chennai just about a week ago is 50 women out of every 100,000 get breast cancer every year. But if you see all cancers put together in women, that has been a straight line, because the rise in breast cancer is compensated by a reduction in cervical cancer. Cervical cancer has reduced remarkably over a period of time. And the last number in the bracket, 7.5 in Mumbai, that has even reduced by even latest figures of 6.5. 6.5 women per 100,000 will get cervical cancer. And I wonder who can take credit for that. Nobody can take credit. We haven't done anything at all for that, except some very vigorous hysterectomies in some parts of India. But that's not the region. That's not the region where there has been reduction. The reduction has been there all across. There is not a single cancer registry where there hasn't been a documented reduction in cervical cancer. So there is obviously something better that is happening as far as cervical cancer is there, and it is reducing. I just want to say one more thing, that 6.5 is the last number from Mumbai Cancer Registry. The WHO's threshold for rare disease is 6. 6 per 100,000 counts as rare disease. And we are likely to spend millions of dollars in vaccination for cervical cancer patients. Please understand, I'm not against anything, but if things are already reducing at breakneck speed, and let's accept that we don't know why is it happening, we do have some inkling as to why is it happening. And some of it, if you look at Barshi, one of our rural outposts of Tata Hospital, where we started a population-based cancer registry in a rural pocket way back in 1982, the cervical cancer numbers in that registry then were about 28 women per 100,000 population. Somewhere in 96, a semi-urban pocket, a textile town emerged 10 kilometers away from rural Barshi, and we call it urban Barshi. By 2004, the numbers in urban Barshi were 15 per 100,000. From 28 reduced to 15 in a span of 8 years. What is happening? What changed between these 10 kilometers apart hamlets? And what changed was a municipal corporation giving running water in privacy of bathrooms. The men in rural Barshi even today have their bath on a common well, putting on their undergarments while they're having bath. What kind of personal hygiene will there be? The possibility that the HPV virus, which is one of the viruses that leads to this disease, but the possibility that it will grow, it will keep on growing, and when this individual has intercourse with another woman, he is going to deposit all that load of virus, and that cervix will have no other choice but to convert into a cancer. That doesn't happen when you have privacy of bathroom and personal hygiene taught. You might say there are 100 other things happening between the two. Why focus only on that? And when we look at the numbers of our Muslim brethren in rural Barshi, in urban Barshi, in Pune, in Mumbai, in Middle East, all pockets, wherever you go, the incidence of cervical cancer is 5 per 100,000 in those communities where there is circumcision. I am not asking everybody to have circumcision. But please understand that there is something good. A religion is allowing you to have a good quality of life. And this is one way of doing it. I was at a camp in Rajasthan, wherein we saw patients, we saw normal individuals, screened them. And at the end of the day, we were having dinner with a local family. And the family had something written on a parchment-like thing, which looked age-old. It must have been, I don't know how old it was. It was written in their own language, and he read it out to me. It read the duties of every individual in a family. So man should do this, the woman should be doing this. The grandmother had one duty assigned to her, that she should teach grandsons genital hygiene only after the age of 9. I feel this statement is full of science. If retraction of prepuce is taught before the age of 9, there would be a surgical complication called paraphimosis, which will need an urgent surgery. Somebody had thought of it a long time ago that cleaning is required, personal hygiene needs to be taught, and it should not be taught below a certain age because it is fraught with complication. Where did this knowledge come from? Obviously, there is some importance given to the age at which the grandmother should be teaching this. Suffice to say, whether personal hygiene maintained by good education, by circumcision, and you also have a choice of vaccination, that you can still have virus and not allow anybody to have cancer. I wonder whether that will happen, because if somebody is vaccinated today, the effect of that vaccination is going to come 30 years down the line, not earlier than that. So screening will be important there. So what I've driven home today is that the numbers are small here. We are fortunate that the numbers are small. We are also fortunate that the number of deaths per 100,000 are small. We are somewhere close to about 60% of what the US deaths are per 100,000 population. There are good things that are with us. Let's maintain that, and can we reduce it further is what we should be looking at. And we are very fortunate that we are less than one third of what US has in our cities, less than 1/9 of what we have in our rural pockets, and 2/3 of these cancers are preventable. 40% of cancers are related to tobacco. 40%. If we stop tobacco production, I mean, if this thought had come about 20 years ago, which was there about 25 years ago also, but to have it implemented multiple times, we've written that, let's say from 15 years from now, we will have zero production of tobacco, zero cultivation of tobacco. And it doesn't happen. It's extremely difficult because the industry buys the product 2 years in advance. The farmers get their money 2 years in advance for what they're going to cultivate 2 years down the line. How are we going to stop this? We need a good collaboration between our revenue ministry and the agricultural ministry to see that an alternative cash crop is given, incentive is given, and not that people don't understand. We were talking in a district called Kheda in Gujarat, which is in those days. Now there is some district in Karnataka that manufactures largest amount of tobacco. But in those days, it was Kheda in Gujarat. And after having spoken a lot about how tobacco is bad, one of the oldest chap in that village mentioned that, "Ye to humko kab se pata hai?" And I asked him as to how is it known to you? He said, "When I was a child, this crop was used as a compound for farmers, for the farm. And if this was a compound, then cattle cannot come in. Cattle know that this is bad." Subsequently, the compound ate away the whole farm. And why did it eat? Because the farmer was saving on insecticide. No insects touch tobacco. Insects also know that tobacco is bad. But we walk from home long distance to buy a cigarette. All good things come very cheap and easy at doorstep, but we walk from there long distance to buy our poison. So suffice to say that 40% of cancers are preventable by tobacco. 15% are related to obesity. Usually after my such talks, a lot of people walk home. Or I see them on treadmills or going to, but that doesn't last for more than a week and then it fizzles out. But there are about 19 cancers that are related to obesity. Even I need to lose weight. Breast cancer is one, ovarian cancer is another, prostate cancer is third, colon cancer is also related. So there are lots of things. But presently, there is so much of food around us that we have forgotten the meaning of the word hunger. And our children definitely don't know what hunger is. When I go to schools to talk about cancer, so there's a little bit of awareness, at least kids will get their parents for screening for the right kind of cancers. I find that all these children are roly-poly. And for these talks, a lot of parents also come. So at the end, there is some interaction with parents, and there is not a single mother who doesn't say that the child doesn't eat. So every mother feels that the child is not eating, but I see the child very roly-poly. So there is enough to eat. We give food because it is time to have food. There is no hunger and there are no physical exercises. You are very fortunate to have a campus of 120 acres. Schools in Mumbai will have 1/3 of an acre with a tall building and everything. If at all exercise behind the desk. You do a little bit of exercise and that's it. So no physical exercise, that's what is required. I was talking to Dr. Vaz about some suggestions as to how bad the traffic is in Bangalore. And he was saying that maybe it has improved quite a bit in Mumbai, and it has improved to some extent with the coastal road. My suggestion at that time, when some opinions were asked from public about the coastal road, was that why don't we make a two-tier coastal road? The upper one is for vehicle, and the lower one should have three travelators moving in one direction and three travelators moving in the other direction. The first one moving at 5 kilometers an hour. You start walking on it, you will walk at 10 kilometers. On an average, we walk at a speed of about 5 kilometers an hour. Get on to the next travelator, that should move at 10 kilometers an hour. If you're walking at 10, stepping onto that should be a problem. You walk at 15 kilometers an hour. Third belt, moving at 15 kilometers an hour. Walk on it. You will walk at 20 kilometers an hour. I want to know which metropolitan city in the world travels at more than 8 kilometers an hour. 8 is the best clock time for Tokyo. That's the speed at which we move to come to work. From Warsaw to Gateway of India, the distance via coastal road is 14 kilometers. Imagine 14 kilometers, somebody walking, breathing fresh air of sea, not producing any pollution, walking for 45 minutes, reaching Gateway of India. Today we take 2.5 hours, sitting at one place, producing huge amount of pollution. We need to have something like that to reduce to create walking cities. Infection is reducing in general. All these cancers that I mentioned there are reducing at a breakneck speed. Hygiene in general has improved remarkably over a period of time. I'll give you some numbers for tobacco. These are numbers for India. This came from Prabhat Jha, and this is a paper in New England Journal of Medicine 2008. There will be 1 million tobacco deaths per year during the 2010, and that number has become a reality. That is a reality, and we need to do something. Here is the data from UK, the topmost line, wherein 16% of individuals who are smoking would die annually because of lung cancer, those who are continued smokers. If one has stopped at 50, that 16% reduces to 6%. If somebody stops at 30, it's 2%. And somebody who never smokes still dies, but at 1% per annum. And in some of these talks, it's usual that somebody stands up and asks that George Bernard Shaw was not a smoker. He was a teetotaler, and he died at the age of 82. And Winston Churchill was a smoker. He had insomnia, so even at night he would continue doing it. And he also died at the ripe age of 83. How do you explain that? The only way I can explain is that if you jump from third floor, there is a thin chance that you will remain alive. But that doesn't mean that I will lift this individual on my shoulder and walk around the streets that it is safe to jump from third floor. If you wish, continue smoking. So prolonged use of tobacco kills, and stopping works. It works anytime. For the government level, there is a nice triple, half, and double dictum. Triple the tax. This is the French dictum. It halves the use and it doubles the revenue. So win-win situation for everybody. This was done for alcohol by the Chief Minister of Punjab. In the first year, tripling of the tax on alcohol, and 400 crores came in as tax. All of it went into health. So you give poison to kill individuals and give money to health. Both ways it works. It's quite like some of the pharmaceutical companies, not some pharmaceutical companies, some tobacco manufacturers, the cigarette manufacturing companies in Japan also had a plant that produced bronchodilators. Win-win situation. That's about the reduction in consumption and increasing the revenue for the government. Tobacco is not just for cancer. It produces hypertension, stroke, myocardial infarction. So everything reduced. You will see reduced cancer, reduced hypertension, reduced heart attacks and strokes, reduced burden on healthcare, and reduced all-cause mortality. No tobacco is the only answer. And imagine our cancer is already 1/3, and close to half of those cancers will be wiped off if we didn't have tobacco. I would love to go out of business, and it's happy to say that at age of 70. Infection. Running water, I've already alluded to. Personal hygiene, I have also alluded to. Good food preservation. And I'll give you an example of what cancer comes out of poor food preservation. Smoked meat is something which is a delicacy. A lot of us consume it. A lot of the Western countries also consume it. But nasopharyngeal cancer is quite unknown in these regions. If you look at our Northeast, this is the only region in India where smoked meat is consumed. And nasopharyngeal cancer is about 8 times more there compared to what Mumbai has, what Bangalore has, what Kolkata has. So there is something different. If you go to the kitchens in any of the northeastern states, you will find that on top of the chulha, there is meat hanging from the roof. Not very far away, the roof is quite low, so that there is some natural way of smoking the meat over a period of time. I don't know how long it remains there. How is it preserved? And obviously, if the meat is not well preserved, there is a virus called Epstein-Barr virus that grows in it. Dr. Menon, correct me if I'm wrong. And that will give rise to nasopharyngeal cancer. Simple thing, if the government were to get the smoking possibilities, industry-related smoking chambers or whatever machines that they can make, and people get their meat, get smoked and take it home. If that's the case, then a lot of this cancer is curable to some extent, but why get it unnecessarily? Easily preventable by good food preservation. I have mentioned about diet. Dedicated cycle tracks are a possibility, provided we have the civic sense not to get into the cycle track with the electrical two-wheelers, with four-wheelers going left, right, and center, wherever the track is. If we can avoid that, wonderful. But walking cities, which I mentioned right at the beginning, can be an important aspect. Screening is a very seductive word. When I say that, somebody diagnosed with stage 3 cancer has 30% chance of survival, and somebody diagnosed with stage 1 cancer has 85-90% chance of cure rate, right? So what kind of logic? Is there any logic required other than this to screen oneself? But all that logic goes out of the window when we look at the data wherein randomized studies have looked at screening versus not. And we find that there are many cancers, there is no saving of lives in spite of early detection. So it should be understood that screening is done only for common cancers. Sitting in St. John campus, I will not look for a tiger or a cheetah. I will look for a cat, a dog, something simple, and that I'll encounter every now and then. So I look for common cancers. I will not look for uncommon cancers. If I were to screen for all cancers, then by the time we start today and finish the last test, you will be ready for the first test of the first cancer. So you will not get out of the hospital ever. So screening is to be done. It should also be understood that the moment you start screening, the number of cancers start rising. Those 7 cancers that I wrote with S in the bracket, that there are a huge number of cancers that have increased in the United States, and that's only because they screen. Unless there is evidence that screening saves lives, it should not be done. That evidence very clearly says that in spite of screening, the lives are not saved for prostate cancer, for lung cancer, for colorectal cancer here only because its incidence is low. The incidence where it is very high, it's worth screening colorectal cancer. Lung cancer also, there is some way of knowing that you can do a CT scan, but the efficacy of CT scan in reducing death rate is only if you have consumed 20 packets a day for 20 years. I wonder how many you will find such individuals. If you are having 1 or 2 cigarettes, that screening is not going to be effective for you. In general, it's good to have cervical cancer screened, breast cancer screened above the age of 50, and oral cancer screened in all the tobacco chewers. You will find that 50% of oral cancer patients are women, and first and the second are entirely women. So screening is effective only in women. If you look at the statistics of cancer patients cured of cancer, a lot of them are women. God has been kinder to women. That the cure rates in with treatment with cancer are much better in women than in men. And I will come to that a bit later. So what decides outcome of treatment? There are various things, whether we have stuck to evidence, and there are ways in which we can uniformly say the same practice is done everywhere, and we don't have much of one-upmanship that somebody else has said this, that's wrong, I'm going to tell you something better. No. Evidence-based treatment and everybody using the same standardized treatment. Specialization, unlike what Professor Prakash Shetty had of unification, we need to have specialization for delivery of care because the outcomes improve. At the same time, we should also have a thought process that allows you to think of everything else as in unison. There are some nice drawings by Escher, wherein there are places where individuals are walking down. They're walking down one square, second part of the square, third part of the square, and come back at the same place where the first square was. So we need to have a complete harmony while we are going down, as well as going up at the same time in our thought process. I will not go into the details of the rest of it, but there are delays in diagnosis. But for uncommon cancers, one need not worry. For common cancers, yes, we need to have awareness. This is one of the methods that we've used, creating books, making evidence-based guidelines available on the net so that everybody uses them and there is a commonality. In fact, these guidelines are immensely implementable. They are implemented today in India, not just in India. When National Cancer Institute, United States did a survey in Africa, they found that the American guidelines are not used. If they were used in about 3% of them, Indian guidelines of National Cancer Grid were utilized in more than 85% of the institutions within Africa, only because they are implementable. That's a kind of a graph of individuals who visit Tata Hospital from various centers. So to reduce the numbers coming to Tata Hospital, we suggested to the Prime Minister's office and to the Parliament that we should follow a dual approach, that we create a national cancer grid, which now has about 350 centers across India following similar kind of treatment. Primarily to reduce migration of individuals. One should have treatment closer to doorsteps and also help get the drugs at a cheaper rate. And also suggested a hub and spoke model, hub wherein all cancers are treated and a spoke wherein common cancers are treated. Uncommon cancers are referred to a hub, and the general principle was for about every 40 million population, there should be one hub. And I'll not go into the details as to what's the cost. Suffice to say that it is doable, that this model we ran in Punjab, in Uttar Pradesh, now we are trying to run it in Assam, that it is possible to run in a cost-effective manner with the least cost to the patient. A spoke for 10 million individuals, that means we would need something like 120 spokes across the country, 130 spokes across the country, which is not going to be so easy. And a model that we ran at Tata Memorial Hospital, wherein treat the whole spectrum of society. If I were to look after only poor, or if I were to look after only rich, my understanding of disease is lopsided. We know that everything comparable the quality of treatment, the type of treatment, everything comparable. Social class is an important determinant of outcome of disease. And we need to have the whole spectrum being treated for you to find solutions which are generalizable. So that's the model that I had proposed for the health ministry. And also, since the health ministry offers various kinds of licenses, some way of documenting what are the outcomes from each center that delivers healthcare. In general, the strategy was to have cancer registration, to have medical colleges having cancer wings so that many more cancer treatment facilities will be available in addition to some standalone cancer centers, and to create human resource. What I spoke up till now was what needs to be delivered, evidence-based care. Who needs to deliver it? A trained doctor in various specialties. In spite of having all that, we find that there is somewhere close to about 30-35% lack of compliance to treatment. Patients leave treatment halfway. And there are various reasons for it. We ran a gap analysis, which I ran with the help of Ms. Nishu Singh Goyal, who planned that analysis after coming to Tata Hospital as a caregiver herself. And we found that there are aspects which we had never thought of. There could be something like commonly known. There could be financial problems. There could be problems with accommodation wherever you are taking treatment. There could be having understanding of disease. Have I fully understood what am I suffering from and everything about the treatment? All that were the gaps that we found patients were yearning for, to understand more. The most commonest thing that emerged out was emotional support. A lot of them were hit by the diagnosis of cancer. All of us are, no question about it. But to give that emotional support, so we created a human resource, and the selection criteria was empathy. You may be an engineer, you may be a commerce graduate, you may be whatever, but willingness to be empathetic. How willing are you and how receptive are you to take suggestions from the surroundings to understand who is in distress? What kind of distress? Do you have that within you to be understanding, to be sentient to what the needs of the individual in front are? With those criteria, we selected individuals. By now, about 140 individuals have been trained. All of them are in position, and there is a huge amount of improvement in compliance. So we may think that we are doing the best, and we may be actually doing the best, but is it perceived as best by the patient is an equally important component to be looked at. So we need to offer an end-to-end solution, not just for the content, but also how is it delivered. I have almost alluded to everything that I mentioned here. We are the pharmacy of the globe. You look at the cost of drugs in India versus cost of drugs in all other countries. We are very fortunate that the best of the curative drugs are available for a common man. Some of the newer ones may not be available, but when I look back of something like in the last 20 years, US FDA approved how many drugs and how many of them make what kind of difference. And that's where misery comes in. The average improvement has been 4 weeks of improvement in life expectancy at a cost which is more than, for Indian population, unheard of, but more than $100,000. How does one take it? And we are comfortable with 95% of the population of the world not affording it, not getting what they need, and yet we are perfectly comfortable in continuing our business. We need to rethink about it, that we need to find solutions which are implementable, cost-effective. So that's where research comes in. And research is not an esoteric idea. It is an idea that needs to come out of day-to-day practice while you see patients on day-to-day basis. To create infrastructure, I will not go into the details, but suffice to say that institution needs to create infrastructure so that a clinician and a pathologist or a non-clinician, all of them are induced to look for something better. We ran this, we got our medical individuals to spend some time in London to understand what difference does it make to do research, what additional qualities need to be put into for you to do research, and also created some infrastructure with manpower to support research and to conduct research. I'll give you just 3 or 4 examples of what has emerged out of this effort. 2 screening trials, one for cervical cancer, one for lung cancer in the same individuals, 150,000 women randomized to have 75,000 having screening and 75,000 not having screening, with a simple visual inspection of cervix with using acetic acid. One could use iodine, one could use pap smear, whichever it is. But this is cheapest. Pap smear costs about $100 in United States. This intervention cost just about 100 rupees. That much of intervention and 30% reduction in deaths related to cervical cancer at the end of 10 years. Today, 26 out of 29 states have taught their healthcare workers who deliver women and child health the technique of visual inspection. That's happening in India. This would have the capability of reducing somewhere close to about 22,000 deaths every year if implemented appropriately. Same for breast cancer. Plain simple physical examination, reducing mortality by somewhere close to about 30% in women above the age of 50. We don't need mammography for that. This is as good. 30% reduction in deaths, and with a 20-year follow-up in 150,000 women who have had surgery, who have had screening for breast and cervical cancer. Some other simple interventions, whether surgery done or not for some head and neck cancer patients, again, 28% reduction in deaths related to head and neck cancer, which is our own common cancer. This is a study that was run by Dr. Anil De Cruz, who is the alumni of St. John's. And this got published in New England Journal of Medicine. 2 other studies I will allude to. And again, simple thoughts, simple ideas drawn from what happens around us. We believe that metastasis is what kills cancer, kills the host. Metastasis is a process by which cell moves from one organ to the other, nestles and creates another disease. Am I taking too much of time? I'll finish that in you may. Thank you. Thank you so much. So a single injection that might reduce the mortality of breast cancer. We ran a study of 1,000 patients and somewhere close to about 10% absolute reduction in deaths related to breast cancer. Exactly similar kind of study wherein local anesthetic injected around the primary tumor before surgery begins. One versus not, 1,600 patient study, again, 28% reduction in deaths related to breast cancer by a simple intervention of local anesthetic. Both these interventions cost less than 100 rupees and save exactly the same lives, same number of lives as one would do paying about 2 lakhs to 5 lakhs of rupees. I would end with saying that we need to address our healthcare access challenges if our economic growth is to be sustained. And healthcare delivery is not a business. When I say that, I have no right to create need in society. I'm not here to create disease in society the way the West has done. We are looking at reducing disease in society. So reducing disease is not something that I would do for our business. But at the same time, all the QA/QC, transparency, everything that needs to be run for business needs to be followed in healthcare. So that's what, and this is not my thought. This is Professor Veliathan, who used to always say that this is not a business because we can't create disease in society. And this is a business because the delivery of care needs same kind of QA/QC that is otherwise required. We need to work towards our own irrelevance. Thank you very much. Manjulika, I'm sorry, I've taken too long a time, I think.
No problem. Thank you so much, Dr. Badwe. I'm sure you will all agree that that public lecture really spoke to us as professionals and as everyday human beings. You connected, with the simple things of life, really down to earth messages along with the number and the statistics. So we are now open to a Q&A session. I'd like you to raise your hands, and then you have a mic in front of you which you can press. Raise your hand, please. Introduce yourself briefly, and I also have some questions which are coming up online. Yes.
Hello, am I audible?
Yes.
So, we are students from Christ University studying clinical psycho-oncology. I'm one of them. My name is Srishti Shedge. I'm from Vashi, Navi Mumbai. I feel so nice to see you here. And my question is, like, as we are from clinical psycho-oncology and you talked about KWAT, like the creating human resources. So, is there any hope for us to join that? Or is there any hope that we could contribute to that?
Nishu, do you
Well,
want to take?
all of you can contribute, but Nishu will be a better person to answer this because she runs that program. She has conceived that program. So all yours, Nishu.
Thank you so much for that question. The answer is short. Anyone who is wanting to make a difference in patient care can be a part of KBUT. And it's a multidisciplinary intake. So we have doctors, we have nurses, we have sociologists, psychologists,
Clinical
and
psychologist.
clinical psychologists. We have pharmacists. We have people who have done masters in cancer biology. We have BTechs. So it is a multi-professional, multidisciplinary intake. We have a screening tests and options that we have they have to clear. But absolutely, you can make a difference, and we'll be happy to have you with us.
I'm going to take one question from the online group and then come back. So this is from Miss Amu Joseph, who's a journalist, and she talks about, she's asking you why from our respectable news media, we read continuous reports about how India is set to be the next cancer capital of the world, and cancer cases are soaring in India. Why do we hear this contradiction and discrepancy?
It is good to come to terms with reality, and it is bad to sell cancer. When that comes in, that we are going to be the capital for cancer, if we were to follow in the footsteps of how the West has gone, we will be the capital. But we need not do that. If we preserve our core as it is in India, I'm sure we will be the place where the whole world should come.
So there is an agenda that is behind those news reports. Okay. Ms. Neha? Neha, sorry.
Yeah, okay, I got it. Thank you, sir. It was a treat. Enjoyed it thoroughly. You just said that food seems to be the cause. I mean, we are eating too much. Do you have anything to say about what metabolism is helpful versus not? Or can we pinpoint to metabolism which is more advantageous?
So there is not much of a problem with metabolism. It's the quantum. Everything in moderation is fine.
Okay.
We need not have poor nutrition. We need not have over nutrition.
So no, I was going from glycolysis to oxphos kind fatty acid oxidation, those kind of metabolism.
It's good to understand as you go into the nitty-gritties of that there are carbs, there are fat, but in nature, there isn't anything like this. There is nothing like pure carbohydrates or pure fat. We have created those. I think each of them are required to some extent for normal metabolism in our body. If that balance is lost, I'm sure there will be problems. But even if you do that within moderate limits, it is still okay.
Thank you.
Our body has an entity called hormesis. You do all kinds of assaults. It will take and it will get everything back to normal. But if that goes overboard, then how many? It's just about 100 out of 100,000 who get that problem. But the rest of them also follow the same thing. But they don't get it. This is the best machine that we have.
I agree. Thank you so much.
Dr. Anuradha.
Good afternoon, sis. Thank you for that talk. I'm a pathologist, and we are increasingly seeing a lot of adenocarcinomas of the lung. In fact, it's one of the most frequent diagnoses we are making in non-smokers among women. I mean, obviously urban. Do you have anything to say about that? What could be the cause?
So the commonest thing that I would attribute it to is the amount of pollution that we have. I'm not talking about particulate pollution. There is chemical pollution on top of that particle. That is what is increasing in women. Passive smoking is another reason why it is on the rise.
So Dr. Sushi online, she is a community dentist, says a very insightful talk. Could you please share your insights as to why there's a delay in detection of oral cancer in India?
Not being aware as to what to look for. One, a great majority of the ulcers, that is the first sign of cancer, are painless. So people tend to forget about it. And it's a very insidious onset of disease. If I have loose motions, I immediately look at what did I have yesterday. So if the gap between the cause and effect is short, then it dawns on me that this is happening, which doesn't happen for tobacco. So even a tobacco chewer keeps on continuing and finally it becomes late. That's one. The second cause is lack of access to good care. If early detection by just physical examination of the oral cavity is done in a tobacco chewer, I'm sure early diagnosis is very easily possible, and access to treatment as and when we have all the hubs and spokes in position.
Thank you for that. The second lung, yeah, that's true. Go ahead. Yeah.
I'm a PhD in social medicine from Chennai. So, as you spoke about the importance of, for the prevention of cancer, the importance of water, personal hygiene, food, preservation, these are much more like, in the advocacy towards controlling cancer, these are equally important rather than focusing just on the treatment. And you have also you also spoke about how the cervical cancer incidence that is declining because of just one or two factors. So how do you create these kind of advocacy forums wherein actually give put across your ideas so that just not the commercial determinants of health they determine what the course of the disease is.
The question is very easy to answer, but not easy to implement, because we don't value what comes at a low cost. We need to have something which is expensive. We also need to have something that comes from the West. We need some champions. We need some champions within our society who will do this. And it needs to be a sustained activity up to about 10, 12 years. Then it becomes part of life. It can't be a kind of in blips that I do it for, it's done for a year or 2, 3 months and then left alone. No, it needs to be hammered in on a regular basis.
So some of these we'll continue discussing over tea. Maybe the last one question. Yeah, your hand was raised. Yes. Can you introduce yourself, please? When you.
Hello, sir. I'm Diksha. And you mentioned that God has been kinder to women. So could you elaborate a bit more on that? And another thing is, based on some researches, it is found that males tend to leave their female partners more when they find out that they have cancer diagnosis or any sort of terminal illnesses. So a bit more on that.
So I kind of shortened my talk there because I was taking too much of time. In general, the cure of cancer is much better, stage matched, site matched for women compared to men. And we were trying to see what is it that might be producing it. So one of the reasons why an individual dies of cancer is because of metastasis. And metastasis is movement of cell from one organ to the other. So we were looking at as to, does this happen physiologically? And it does happen in women. With every menstrual cycle, there is ovum that leaves ova, gets into the tube and goes to the uterus. That's movement of a full cell, which is exactly what we call metastasis. Nature uses it. Then what's the insight? The insight is very simple. What's the incidence of twins? Uncommon. What is the incidence of dizygotic twins? Non-similar twins. Twins are uncommon. Non-similar twins are even more uncommon. What does that mean? That means one ova extruded, the second ova will not be able to move. If you ask a gynecologist, when she looks at the ovary, before ovulation, 4 or 5 follicles get ready to be extruded, but only one extrudes. What does that mean? That means very simply that when the first one is extruded, there is a switch that stops movement of cells. The next cell is not allowed to move. And what do I want during treatment of cancer? The cells should not move. What is it that stops movement of cancer? The moment the ova leaves ovary, the lining within seconds starts secreting progesterones. And progesterones reduce movement of cell. It increases the cell-to-cell adhesion so much that cells are not allowed to move. What we did was giving an injection of depot preparation of progesterone 4 days prior to surgery to 500 women, and 500 women did not have it. A difference in cure rate of 30%. So when nature gives some problems, it also gives you solutions. That's one. And the corollary of that, if Professor Higgins wanted to say that why can't women be a little bit like men, I would redefine that by saying why can't men be a little bit like women to live longer?
Thank you very much, Dr. Badwe. So as you can see, Dr. Badwe is so engaging and so knowledgeable, we could go on, but it's time for us to show our gratitude by saying thank you to him for coming all the way and delivering this lecture. So I call upon our Associate Director, Reverend Dr. Associate Director of the College and Research Institute, Reverend Dr. Charles Davis, to hand over a token of our appreciation to Dr. Badwe. Thank you very much. Our Dean of the Research, Dr. Tony Raj, he's really been a backbone behind all our annual public lectures, and this one in particular. I call upon Dr. Tony Raj to deliver the vote of thanks.
Padma Shri, Professor Rajendra Badwe, our distinguished speaker this afternoon. Our director, Reverend Father Jesudas, unfortunately had to leave early. Reverend Dr. Charles Davis, our Associate Director of the Research Institute and Medical College. Other executives of the Academy, family members of Professor Prakash Shetty, dignitaries in the audience and online, Ms. Nishu Goel, faculty, invitees, students, and guests who are here as well as online. It's my privilege to propose the vote of thanks for the 6th Professor Prakash Shetty public lecture this afternoon. And on behalf of St. John's National Academy of Health Sciences. I would especially like to thank Professor Badwe for delivering this year's lecture on Indian society and cancer. I think you will all agree that it was a fantastic lecture and he was so articulate, was able to explain this as to the health professionals and to the lay people. So thank you so much, Professor Badwe. It really spanned the realities of cancer and its advancements in the context of India and gave us hope. Your lecture did give us hope with very simple messages. The public messages were very important and it really alluded to this whole philosophy of this lecture. So thank you so much. I'm sure Professor Shetty would have been very pleased with today's lecture and the engagement that it's generated. We also thank Professor Badwe for donating his honorarium back to the Research Institute, and the Division of Health and Humanities will use it fittingly. I would also like to thank the family members of Professor Prakash Shetty who have joined online, and I'd especially like to thank Professor Nandini Shetty, who was also my teacher many years ago, and his children for being here this afternoon and facilitating this lecture. I thank the executives and especially our director and the management for being supportive and for their constant support for all the academic activities here. I'd like to thank Dr. Sumitra Mutaya for introducing Professor Prakash Shetty as a person to the audience, Professor Hari Menon for introducing our distinguished speaker, Dr. Manjulika for being the host and for anchoring this lecture, not only today, but over these years, Reverend Dr. Charles Davis for honoring our distinguished speaker. Also the organizing committee, including Professor Mario Suarez, who's in Australia, and Manjulika and others. My gratitude also goes around to the Division of Health and Humanities and their staff, as well as Dr. Radhika Hegde, who's here, who's been helping with organizing this lecture. Thank you, participants, for being here, and those of you online for devoting your afternoon. And all of you who are here from St. John's and outside. And finally, a big thank you to the technical team, Rajat, Maharaj, Rajan, Ali, Sharat, and colleagues, the admin team, Prakash, Cynthia Vanaja, informatics team, Dr. Dinakaran, and everyone behind the scenes who made this lecture a success. To all of you who've been here today, there's tea and coffee being served outside. Please join us. Thank you so much.
Thank you, everyone.